Stanford University.
Welcome to the seminar on People, Computers, and Design. This is the last session of the quarter, so a couple of administrative things. If you're taking it for credit, and if you have been here for every talk and managed to find a sign-up sheet, you're done. Otherwise, we'll be sending out an email telling you what you need to do to get credit. Just have to email some stuff back into us. And Ranjita will be sending it out. I want to thank Ranjita, who actually can't be here today, for helping out during the quarter. Also, Lance and the crew up in the booth there for doing a great job. Thank you. We will be starting again first Friday of spring quarter, and I wanted to say a couple of words about the plans for that. We're having a focus on design. So as opposed to the sort of complete smorgasbord of different topics that we tend to have over most quarters, Stephen Dow, who's a postdoc here, has put together a series of speakers in different aspects of design, and we're setting up an auxiliary course. So we'll be having a course, I think, called CS 549, which will meet for the 2 hours immediately following this talk. And we're going to ask the speakers to participate in that. We'll get a discussant, we'll have papers, so it will actually be more of what you think a seminar means, as opposed to this, which really isn't a seminar, even though it's titled that. And it'll be a separate 2-credit course. Although you have to sign up for, if you sign up for that 2, you also have to sign up for this 1 with it. So just as an option for some of the regular students who want to take that course. That's not going to be open, it's not going to be televised, it's more like a real course. Yes?
Is that one not in the Stanford bulletin?
It isn't even through the curriculum committee yet. So the answer is no, it does not have any visible presence. That's Stephen up there, so if you have questions about it, I've been talking about the course next quarter.
Okay.
He can tell you what the plans are. We're working to get it into the various official forms right now. Okay, today we have Tim Bickmore from Northeastern University, and he did his PhD at the Media Lab at MIT, working with Justine Cassell, who gave a talk here last year, and is now at Northwestern, not to be confused with Northeastern. And it was on having realistic characters, computer-generated anthropomorphic characters. He then spent 2 years in the medical school and is focusing on questions of health. So there's an interesting confluence here of taking his initial work on anthropomorphic characters and looking at how they can be used for promoting better health. And that's really the general focus, and we'll be talking about that.
Thanks, Terry. So again, I'm at Northeastern, which is not in Chicago. So this is within the College of Computer and Information Science. In my lab, I have a dozen students and staff working with me. They're from departments from all over campus, so from our animation program and from industrial engineering and exercise physiology and other health departments, because as you'll see in a minute, most of the work I'm doing is in healthcare. So I'm going to give my talk in 2 parts. So the first half will be sort of a quick overview of our research program, and then the second half will address the title of the talk, which is some observations from a number of studies that we've done over the years that seem to indicate that the kind of character-based interface that we've been doing are not only accessible and usable by individuals with low domain knowledge or computer literacy, but are actually preferable. They actually seem to like these more than individuals with high levels of computer literacy. Okay, so what we do in our group is study this and try to model this as closely as we can. So one-on-one, face-to-face conversation between health providers and patients. So doctors and patients, nurses and patients, therapists and patients, and looking at everything that goes on in this intricate dance in this brief counseling session between the 2 of them. So both the verbal channel that's used for therapeutic content, and also content of the speech that's used to build trust and rapport, and what's called a therapeutic alliance, or better, the working relationship between the provider and the patient. So this working relationship has been shown in a number of studies to lead not only to improvements in patient satisfaction, but also to improvements in adherence. So the patients are more likely to listen to what the doctor is telling them to do, and because of that, they have better health outcomes. In the nonverbal channel, we're also interested in looking at everything that's going on there. So probably a lot of things that Justine talked about when she was here, so use of hand gestures for conveying information, gaze cues for turn-taking, body posture shifts for marking topic boundaries, displays of attitude towards the patient, and also displays of emotion, so comfort and caring and empathy in the interactions that are going on. So I should say that we model these behaviors in very limited domains. Our basic design methodology is we go out and we videotape. We find ideal models who are doing the kinds of behavior that we want. We videotape the interactions. We do sort of detailed modeling of verbal and nonverbal behavior, build it into a system as best we can, and then we start our series of usability studies and fine-tuning until both the clinicians that we work with and the representative patients are happy with the final system. Okay. So if I want the computer to do hand gestures, I have to give it hands. If I want it to do head nods and facial displays of emotion, I have to give it a face. So the kind of interface that we end up with looks like this. This is our virtual discharge nurse we have at Boston Medical Center that's discharging patients from the hospital. So we wheel this up bedside just before a patient's ready to go home. And a patient has about a half an hour to an hour-long conversation with this virtual nurse about everything they need to do once they get sent home from the hospital. So most of it's focused around medication taking, so all of their meds, expected or possible side effects, follow-up appointments, anything else they need to know to take care of themselves once they go home. The style of the interaction is the character talks using synthetic speech. That's because we have a dialogue engine and text generation that's actually dynamically assembling all of the utterances based on information from the patient's medical record, discourse context, what they just asked about, and other information. Synchronized animation, that's displaying the nonverbal behavior for the virtual nurse. So we try to focus a lot on the output side of the system. The input side, the patients would love to be able to talk to the character using unconstrained speech, and of course we'd love that too, but this needs to actually work reliably in a healthcare setting and in home settings. So for the most part, we populate a list of dynamic choices over here of things that the patient can say at each turn in the conversation, and they pick it off a touchscreen. So we find that this interface works very well even for patients who have never touched a computer before. They can learn how to use it in about 10 seconds. Basically, the character walks on and says hi, and they inevitably wave and say hello, and you say, no, you just touch what you want to say, and that's the end of the training. And from there, they're off and running with the system. And it supports sort of a natural flow and the look and feel of a face-to-face conversation, even though the patient side of it is extremely constrained. Okay, so why are we focusing on health? Well, obvious reasons. Health behavior is a major driver of morbidity, mortality, and healthcare costs in the US. If you could just get people to stop smoking, stay on a diet, exercise regularly, of course, you can have huge impacts on health. And if you can even have minor changes on a population-wide level, you can have very big outcomes as well. And why character-based interfaces? This is maybe the point of the talk. We find that it's very accessible. Let's get rewired here. Accessible and learnable by patients who've never touched a computer before. Also those who have low domain knowledge, who don't know much about healthcare, seem to be able to, since they know how to do face-to-face conversation, they know how to read all of the cues that the character's producing and find this a natural and engaging style of interaction to sort of step right into and run with. Another reason for characters is this notion of therapeutic alliance that I just mentioned. So I want to build a sense of trust and rapport, both for purposes of adherence to the regimen, but also in long-term health behavior change interventions. We want people to come back and talk to our characters maybe daily for years, or if it's chronic disease self-care, for the rest of their life. So we really want them to sort of have a sense of accountability and bond with the agent that we want to establish over time. And most of the cues that people use, or many of the cues, are nonverbal in nature. So again, facial displays of emotion and caring, proxemic cues, so orientation of the body and closeness, and other sorts of behaviors that are difficult to display if you didn't have a character. And finally, an area that we've been focusing on in the last couple of years is health literacy. So this is individuals, it's basically domain knowledge, but it's individuals' ability to read and follow written medical instructions. So like read a prescription, read your discharge instructions, and to act on it appropriately. So it involves both reading literacy, knowledge of healthcare concepts, numeracy, and other factors that go into being able to successfully execute on written medical instructions. And we've been looking at how to simulate what providers do when they explain written medical information to patients. So the literature says, of course, you want to simplify the written language as much as possible, incorporate the use of images and pictographs as much as possible. But beyond that, you want a provider sitting down with a patient, walking them through the document, scaffolding, telling them where the information is to be found, answering their questions, testing their comprehension. And these are all kinds of things that we can do using both verbal and nonverbal behavior. Okay, and we've applied this to a number of different areas in healthcare. We've had 5 systems that we've finished clinical trial on. We have 7 more out in the field right now. Most of them so far in the area of preventive medicine or wellness. So a lot of them in exercise promotion, diet promotion, UV avoidance for cancer, skin cancer prevention. In the inpatient setting, we just started a pilot test a couple of weeks ago on a system at Mass General Hospital to counsel patients on their options for anesthesia before they come into the hospital for surgery. So the idea is to let them know what their options are, the risks and benefits of each, and to identify additional questions that they might have for their provider so we can print out a report for their anesthesiologist so when they come into the hospital they have a much more efficient conversation with their anesthesiologist. And then on the discharge side, I just showed you a picture of the virtual discharge nurse. I'll show you a demonstration of this in a moment. This has been under trial for about 1.5 years now and should finish the end of this year. Once patients get sent home, we have the problem of keeping them on medications. So we've done systems in antipsychotic medication adherence for patients with schizophrenia, and now we're working on a version of the virtual discharge nurse that will follow patients home once they get discharged to continue reinforcing medication adherence and determining if they're having adverse drug events. And then finally, in the outpatient setting, we've done a couple of systems for geriatrics exercise promotion, and right now working on preconception care, which is to address disparities in infant mortality and low birth weight, particularly in young African American women, by getting them as healthy as possible before they get pregnant. Okay, so let me give you a quick snapshot of what's under the covers and driving these systems before I talk about all of the different studies that we've done using them. Most of the systems we have out in the field use hierarchical transition networks or augmented transition networks to model the dialogue flow. A typical system will have between 2 and 10,000 states of dialogue. So typically, a state will represent something the character says or asks the patient, and branches represent things that the patient can say in response to that. A couple of our recent systems have built on work that Chuck Rich and Candy Seidner have done over several years on the collagen dialogue planning system. So Chuck has an open source reimplementation of collagen that we've extended for use in dialogue planning. And in this model, it's basically a task decomposition planner. So you start off with a mutual goal, like having a counseling conversation. And then you have a library of plan fragments or recipes that get selected. So for example, one way of having a conversation is doing a greeting, a counseling body, and a farewell that gets plunked into the tree. And then you further continue expanding that until down at the leaves of the tree, you have actual utterances, things that the character says to the patient, things that the patient says back to the character. And then by maintaining a focus stack of your path through this tree, you can do things like reference generation more efficiently. Okay, so whatever the method of dialogue control we're using, at the leaves of the tree, the character has to say something. So we use template-based text generation right now with XML tags that specify the nonverbal behavior for the character. So in this case, we're specifying that we want a head nod and a beat gesture, which is a biphasic gesture that's used for emphasis with the hand. And the coordination with the speech is important. So we're saying we want those two things to occur right at the start of the phrase blood pressure. So it's for your blood pressure. We would like to be able to go through and hand annotate where these things occur, but in our systems with thousands of dialogue states, it takes somebody with a little bit of knowledge of linguistics to be able to do this, and so it takes quite a bit of time. So we use an engine that I co-developed with Justine and other researchers at the Media Lab called BEAT that takes the utterance that we want the character to say to the patient and then annotates it with nonverbal behavior that would accompany the natural delivery of that text in speech by the character. So specify where hand gestures would occur, head nods would occur, and so on. And the way we do that is through first doing a shallow linguistic parse using a part of speech tagger, building up a parse tree, keeping a discourse history of what's been said before. So most nonverbal behavior occurs in the new part of the utterance we call the ream. And then we have a bag of rules from studies that we've done and other researchers have done that say where different kinds of nonverbal behavior should occur. And using those rules, decorate the tree with different nonverbal behavior, and then finally synchronize this with the speech channel in the animation production. So we use this as a general framework for whenever we want to generate a new kind of nonverbal behavior, like pointing at a document. We go out and do some studies, come up with the rules for generating those, and then add it into the system. So since our typical system has thousands of states of dialogue, and since doctors often care about exactly what their patients hear, we've spent a lot of time developing tools that we can use and clinicians can use directly to author and test dialogue. So we have visual design tools that let them author little dialogue fragments, push a button and have the character pop up and speak it, as well as generating text and speech transcripts that the doctors can read through and validate. And then runtime environment, we can separate out the character as a digital puppet from all of the brains of the system so that we can deploy just the character on home computers or on mobile devices, for example, and then connect into the server for all of the dialogue content. And deploy this to lots of different platforms so far. So home computers and kiosks in the hospital, mobile devices. This is our bedside patient education system, and also through voice XML conversion for our IVR systems. Okay, so I'm going to talk briefly about some of the systems that we've built and evaluated. First, in the area of exercise promotion. So there's a number of commercial devices now that are small pedometers or accelerometers that you wear, and you can upload the data to a website for tracking and goal setting to see how well you're doing. So we did a project with Partners Center for Connected Health, their telemedicine organization, to evaluate how well biweekly counseling with one of our agents compared to just uploading your data and trying to manage the process yourself. So in this case, we used a device from a company called FitSense. It's called a FootPod. It's about the size of a quarter, clips on your shoe, keeps track of your walking behavior, and when you walk near your computer, it automatically uploads your steps, and then uploads from there to your website. And compared people who were just using that device and the website to those who also had twice weekly conversations with the agent. And in this case, we're able to show that we did significantly better at increasing steps over baseline over the 12 weeks of the study. This is a project we just finished with Abby King here at Stanford Medical. So this was our first bilingual counseling agent. So this is designed for older Latino adults. We set it up in a community center in San Jose. And they had twice weekly conversations with it for 4 months for the intervention. And compared this to folks who were on waitlist control, so had no intervention. And just looked at the data yesterday and saw that based on standardized self-report measures of physical activity, we did significantly better compared to the control group. All right, so finally let me talk about hospital discharge. So this is one of these transitions in care in our healthcare system anyway that until recently hasn't been standardized and is kind of broken. But this happens a lot. There's 40 million discharges a year that are done. In the US, this takes about 8 minutes. So it's here's your stack of prescriptions, maybe some educational information and a pat on the back and good luck. So partly because of this, there's been studies that have shown that after discharge, if you ask patients why they were in the hospital, only 42% of them can tell you what their primary diagnosis was. And only 37% of them can tell you why they have any given medication. You can hand them a pill bottle and say, what's this for, and have no idea. Partly as a result of these problems and other problems, 20% of patients get readmitted to the hospital or the emergency room within 30 days of discharge. So this is a major cost driver to our healthcare system, and this dealing with this bounce back or this hospital readmission problem has become a major area of focus for a lot of researchers. So we've been working with a team at Boston Medical Center that have been trying to fix the hospital discharge process, led by Dr. Brian Jack. And he's come up with a standardized protocol for doing discharge. So if you do all of these things, that's the best way we know how to do hospital discharge. This was adopted by the National Quality Forum last year as a new standard. And a number of these have to do with patient education. So it's coming up with a discharge plan that's written for the patient instead of the clinicians. Having a nurse sit in the room with them for half an hour and making sure they actually understand all of their discharge instructions. So actually testing their understanding of that and reinforcing it if they don't get it. And then having a nurse or pharmacologist calling them 3 days post-discharge to see if they're having any problems with their medication. So this is the after-hospital care plan that they designed that's designed for patients with low health literacy. It has things like medications color-coded by time of day, what the medication's for, how you're supposed to take it. And this involves, again, a study nurse sitting in the room with the patient for about half an hour on average in their studies. And they showed in a clinical trial that ended last year that if you do all of these things, you can significantly reduce the readmission rate relative to standard of care at Boston Medical Center. So they'd like to disseminate this to all hospitals now, but of course, they don't want to go out and hire an additional army of nurses just to do the patient education piece. So we started working with them a few years ago to say, can we just not replace, but can we automate the nurse education part of this so that hospitals are able to adopt this new standard? So the development effort on this took several years and involved writing a massive amount of dialogue content, mostly around medications, the most commonly prescribed medications in their formulary, the most common diagnoses. So this is on a general medicine floor of the hospital that this is deployed on. So we take all patients, regardless of what their condition is or what their medications are. And the way the system works is at discharge time, a study nurse sits down and enters their information into our system. We print out the after-hospital care plan. We download that to the cart, wheel it up next to them, and then they have this half an hour long conversation with the nurse. We hand them the after-hospital care plan, and the virtual nurse basically walks through and explains this, answers questions, tests for comprehension on certain key points. Yes?
How long does it take for the nurse to enter the information into the system?
So right now, we don't have a link to the hospital EMR, so it takes something like 15 minutes. But if that piece were factored out, it would just take, it should be a button press, and it's not. Most of the information is their discharge medications. Yep. And then we output a report for the human nurse to come in afterwards and follow up with the patient, any questions or problems that they had that we couldn't address. Okay, so I can attempt to show a little demo of what this looks like, the first few minutes of interaction.
Good afternoon. My name is Elizabeth and I am here to help you with the discharge process here at Boston Medical Center. You are Timothy, is that right? It is great to meet you, Timothy. As you might have noticed, hospitals are very busy places. My job is to make sure that before you leave, you feel that you have been given all the information you need to help make the transition from here to your home as smooth as possible. So, are you Red Sox fan? That is awesome. I would really like to see games someday, but they don't allow computers at Fenway Park. Anyway, so, how are you doing today? That is too bad. Tell me more about how you are feeling. I am sorry to hear that. I know it can be stressful to be in a hospital. I hope you become more comfortable soon. Make sure to ask your nurses any questions if you think that they could make you feel better. I will now be going over some information with you. It looks like you are going to be leaving the hospital soon. I know you must be looking forward to leaving the hospital, but before you go, I want to review some information with you. This is care plan that we created just for you. Remember to bring this booklet with you to all of your doctor's appointments. On the front, it has your name. And this is the day we are hoping you will leave the hospital. Down here at the bottom, it has the phone number of your discharge advocate. A discharge advocate is nurse here at the hospital that makes sure you have all the information you need before you go home. You can call them if you have any questions about this booklet.
Okay, I'll stop it here. This goes on for a while, half an hour to an hour, depending on how many medications they're getting discharged with. So we've done lots of evaluations on the system, first in the lab and then pilot studies. Now the clinical trial that's underway. And the most interesting process measure is after this half an hour of conversation, we asked them, would you have rather heard this information from your doctor or nurse? And actually the majority of them say no. And we asked them why. There's a number of reasons, but mostly it's that they don't feel pressured and they don't feel talked down to. If you've spent time in the hospital, you spend most of your time staring at the wall. The providers run in and do a test or maybe ask you a question, and then they run out again, and then you're left alone for a long time. So patients really liked the idea that there was something that was spending time with them, paying attention to them, answering their questions about their health condition, and that wasn't condescending. Yeah?
Can we back up?
No. At the end of each section, they can go back and re-review the section again. But right now, and at the end of every utterance, you might have seen, you can ask for clarification or for it to be paraphrased. But not, we don't just have a backup button. Yeah.
I'm curious about some of the design choices.
Yeah, sure.
Like the rendering style of the characters is sort of cartoonish, stylistic, which I think is good. It sort of brings out the empathy. You can focus on things that sort of create the emotional connection with the patient.
Mm-hmm.
And also the choice of the linear structure of the content, taking through one by one in a certain order. There's things that you thought about other options. Did you experiment with other possible choices there?
Let's see. So the linear option was based on observations of what the discharge nurses did in the study. And they basically followed the book through beginning to the end. They would branch off, and in some places they would provide scaffolding for, say, the whole medication section, which might span 3 pages. They'll first give an overview of it and then go back and talk about specific items. But by and large, it was fairly linear. So is that that sort of linear is what you're referring to, or the fact that most of the time they can just say okay?
Yeah, and because I would think that some people would get frustrated.
Some people do.
The pace that it goes. And,
Yes. So that's like the second part of my talk.
Okay.
So basically the short answer is individuals who have either low domain knowledge or low computer literacy seem to prefer this because it's sort of hand-holding them through the whole process and spoon-feeding them the information, if you like. But the patients who are very proficient with computers and have a lot of domain knowledge sort of just want to drill down to the 2 bits of information that they need and don't like it so much. That's sort of my point. Yes?
Maybe you're going to get to this later in your talk too, but have you studied any folks that also have like family members or other caregivers with them when they get discharged? If so, how does that change? The experience in these numbers?
Yeah, so we have observed if they have other family members with them, they'll often sit next to them on the bed while they're going through this process. And we've added in some very trivial acknowledgments of that, like you have somebody else with there and, and just acknowledging their presence, but that's about it.
Go on, I'm sorry.
No, that's...
I was going to say, do you know if the family members or other caregivers prefer the agent? Do you have any numbers on
Oh,
how
we
they
haven't
feel
interviewed
about
them.
it?
That's a great question. We haven't interviewed the family.
Anything anecdotal?
Just that often they're paying more attention because often the individual in the hospital is maybe not as coherent as they should be, and the person who's come with them is there to help them out. Most of the time it's the person in the hospital bed on their own. So it's only the minority of time we have other family members there. Now we're just finishing up a system now that will follow them home and will be a web-based system. And in that situation, we're probably much more likely to have other family members around when they have this conversation. So that's a great thing to follow up on.
I'm still really shocked by this result right here. So you would think that with the opportunity to speak to a real person, a live person, I can ask follow-up questions, I can stop you at any time and say, wait, I didn't understand that. Yeah. Whereas when you're talking to an agent, you may not feel like you have those opportunities. And
So this seems to be holding up. This was in our pilot study with 19 patients. It seems to be holding up now with 158 patients who've gone through our clinical trial. The percentages aren't quite as big, but it's still preferred doctor or nurses in the minority.
Everybody comment here, because you probably haven't been in the hospital lately. You said you could stop the doctor and ask a question. That is a huge social, political,
Bad
psychological
assumption.
battle, right? That doctor does not want to be stopped to ask a question. So I think that's what it prefers, if there isn't that sense of, I'm taking, you really have this attitude of, I'm really busy, you're bothering me, you're taking my time, let me just get out of here. And unfortunately.
And which doctor do you ask? You've seen 10 of them come in your room in the last day, yeah.
I mean, just building on that, I was going to say, before Terry said that, I wonder if you could use these results and use finer-grained results that you get from this as a way to drive the improvement of doctor-patient relationships, to really identify what the problems are.
Yeah, so we've talked with some doctors about having an agent facilitate shared decision-making, so trying to enhance that one-on-one interaction. So there's some interesting space of interventions to do there.
I think this seems like a fantastic way that you could start doing, really simple, like, A-B, you put up that list of, like, this is the way to discharge a patient, right? But I have no idea, sure, that's probably better than what I would have thought of, but, like, that list can probably be improved, too.
Oh, sure.
So, I wonder if you could do simple things like this sort of thing, where you A-B test, does this, this pathway work out better than this way, and really get some controlled numbers and say, now we actually know something scientific about how to do this process.
Yep.
That maybe
We're doing a few sub-studies as part of this. We're manipulating the sociality of the agent. We're manipulating race and gender of the agent. I think that's it as far as the agent interface is concerned.
Have you thought about blending the agent with video? So my hunch would be that there are some things where, you can say, cue story 37, and we explain how to use whatever it is, or what they should know. And it seems like there are some parts that are highly interactive, and other parts that are roughly scripted. And my hunch is that video may be better for the parts that are roughly scripted. Maybe wrong.
Why is your? Why do you think that?
Only because the language. So the thing that made me think of it is, in a bunch of dialogue-based speech user interfaces, you'll pre-record humans speaking a whole chunk for the common clip. So as opposed to, hello, welcome to Stanford University today, you'll pre-record, hi, welcome to the Stanford University HCI seminar. Today's speaker is. And then you'll blend that with a more computer-based. And I'd be curious to see, does that work with agents and video as well?
Yeah, so that's a great study. Another study I want to do is just if we have the agent simply sit there and give you a 5-minute monologue without any interactivity involved versus just having to say okay at the end of every turn, does that make patients pay attention more and do they learn more? But that also gives us the opportunity for doing tailoring to the patient. If we do the interactive version, you can make it more interactive, whereas the video is just, you're kind of stuck. Yeah.
So discharge is one part of transition care, and to avoid doing that, that's also. And you did mention the web-based system to have this system available at home. But therapeutic interaction changes when people actually face the complications of wound care, for instance, stuff like that. Or watching
Let's see. So there's some very interesting problems to solve there that we're starting to look at in terms of doing long-term interactions, repeated interactions with the character. We've done a lot of this in the preventive medicine space, but now doing medication adherence promotion post-discharge is something we're just starting to look at. So one issue you have to worry about, of course, is just maintaining the engagement again, getting them to interact with the character on a regular basis. Another thing, untested hypothesis, is that you want at least the therapeutic parts of the conversation to get more efficient over time. So studies that have looked at repeated measures between patients and doctors show that social dialogue component remains constant, but the task part of the conversation gets more efficient as they learn how to talk about health issues more efficiently, using more concise language and so on. So what we're doing is initial conversations at home are going to be very detailed and somewhat verbose, as is the discharge system. But after you've talked to the character 2 or 3 times about any side effects you're having, we can just pop up a checklist and let you, as efficiently as possible, skip through that part of it. So I've had patients ask me about that. We've done some studies showing that superficial variation leads to increased engagement over time and increased use of the system over time. So yes, I'd like to do that. Yeah.
Sorry, one more question. You may get into this later on. But since you said that you had done studies of engagement, I was wondering about the story at the beginning when she was asking about the Red Sox. Have you done any studies to see if that increases the engagement or the rapport?
You're a perfect straight person.
Okay.
This is like at the very end of my talk, but I guess I could tell you now. So this is something I was very interested in because a number of researchers that I've worked with felt that it's somehow being dishonest or unethical for the character to start talking about itself as if it were a real person with a real backstory. And then I have patients in our preventive medicine applications telling me, I'd really like to learn more about the patient and have more about the character and have that interaction be more personal and engaging somehow. So we did a study to look at if it tells stories about itself and its own childhood and its own background versus the exact same stories as being told about somebody else. So we're controlling for the story content, and it's just, are we making the character more human or just relating stories about somebody else, and looked at engagement. And what do you think? So we saw increased self-report engagement, increased use of the system when it told the stories in first person. So objective measures of system use. And they didn't find it to be any more dishonest or deceitful when it was doing it. In fact, they found it a little bit less honest, less dishonest when it did that. So,
I'm just an actor, but I'm very engaging.
No, but
Taking another facet of the genuineness of it.
right.
And whether it's understood, we understand.
Yeah. I think the patients who use our systems by and large understand that it's just a computer character. And it reinforces that periodically. But they seem to like this other piece, whether it's pure entertainment or some other aspect of having a closer personal relationship with it, I'm not sure. Yeah.
Yeah, if you were to extend the system for patients who are not comfortable in English, to what extent would you have to extend the underlying system of gestures and nonverbal communication, which can often be culturally specific?
Right.
Would that involve a lot of extra work?
So we did just do this for the project we did with Abby King for older Latino adults. And to do it well, again, we would want to look at videotaped interactions and try and understand are the hand gestures they're using and where they occur in speech consistent with the way that we've been doing it before. The underlying rules that we have for generating nonverbal behavior, the mapping from features in the parse tree to conversational function, like emphasize something now, take the turn now, those should be universal across languages and cultures. But then the mapping between conversational function and the surface behavior, exactly what form of hand gesture should I do here, how big of an envelope should I make them in, tends to be cultural specific. But so the short answer is, so you'd have to do a study to see, or do literature review and find out how to do those new mappings. Okay. So this was now the point of my talk. So after doing a number of these studies, it seems to be the case that not only are individuals with low computer literacy and low health literacy able to use our systems, but there seems to be growing evidence that in fact they actually like them more than patients who have high levels of computer and health literacy. So I want to talk about results from a few studies that we've done that indicate this. So again, health literacy is this idea that it's individuals' ability to read and follow medical instructions. It's a big deal because the prevalence in the U.S. is actually really large. About a third of adults in the U.S. have low health literacy. And there's been lots of studies showing, as I said, major health consequences. So people with low health literacy have more likely to be hospitalized, have higher healthcare costs, have poor chronic disease self-care control, and so on. Okay, so one of the first studies I did was in a geriatrics population at Boston Medical Center. So this is a safety net hospital in Boston. So the population is largely urban, largely minority, largely low SES. And so I did an exercise intervention out of the geriatrics clinic, not only to see can we promote exercise, but as much to see would this population be accepting of computer character counselors in their living room. So I went for a pilot study, installed a touchscreen computer in their homes for 2 months that they were going to have a daily chat with, and did a small pilot study. We had about 10 people in each group, and the 10 people who talked to the character, half of them had never touched a computer before, and otherwise low levels of computer literacy. And what I found was, first of all, they found it really easy to use, no problems at all. Even if they hadn't touched a computer. High levels of satisfaction with the system, and at the end of 2 months, desire to continue. So these are just on scale measures. High levels of felt relationship with the character, feeling like it's a close friend. High levels of trust in the character and liking of the character. We doubled the amount of walking they were doing relative to the control group. But then when I talked to them, I found out that they really did like it, and they seemed to really enjoy the social aspect of the interaction. So most of our conversations, we have some amount of social chat that we do with them, and they seem to actually want a lot more of it for this particular population. And this first quote was from a woman who is the most vocal critic of the whole thing, who just didn't like the idea of something being set up in her living room or this computer character. But at the end, when I asked her, so what do you think about this whole experience, the fact that it actually got her out to meet her neighbors, which she hadn't done before, and get out and do some exercise and walking, she thought was great. No. Oh, the Laura? No, that's the character. No, it wasn't Laura Croft. And they also seemed to really like this social and relational part of the interaction and wanted more of it, wanted to learn more about the character. Now, I thought maybe some of this was due to social isolation issues, but like the second quote was from a woman who lived in a multi-generational home. So even folks who are surrounded by people and have lots of friends seem to really like this. And they seem to also like the touchscreen modality. They would prefer speech, but they definitely didn't want to touch a keyboard. So with this population, at least, we found that they were able to quickly get up and use the system, enjoyed the experience, and had high usage and retention throughout the 2 months. And we're currently scaling this up to a 420-patient clinical trial at a Boston Medical Center. That's a year-long exercise intervention. We've also done a series of studies looking just at having agents explain different kinds of medical documents to patients. So prescriptions, research-informed consent, discharge instructions, and did studies looking at, again, how nurses explain documents to patients, so the kinds of hand gestures they make when they're introducing different topics, the kinds of gaze cues that they're using at different points in the conversation. And the most recent lab study we did, we were intentionally looking at high versus low health literacy patients. So this was a genetic counseling study informed consent document. So it has a lot of novel concepts in it. And this is a knowledge test at the end of this intervention. So we were comparing having the agent explain this document to them versus a human research assistant explaining it as the way it's normally done versus locking them in the room with the document and having them read it. And found for those with adequate levels of health literacy, the agent actually significantly outperformed the others. But for those with inadequate health literacy, we didn't do significantly better or worse, but we did pretty bad overall. So we're continuing to work on this issue of using intelligent tutoring system techniques to try and do better. But when we asked them how much they liked the experience, regardless of health literacy level, they liked the agent interaction better than the human or the self-study. And again, for a lot of the same reasons we saw in the discharge case, they liked having as much time as they needed to talk to the agent. If they wanted to ask the same question 5 times over, they could do that without feeling stupid. Okay. And then finally, this is the clinical trial we have going on with the virtual nurse right now. So we've had about 200 patients now who have been discharged using this nurse. So this is overall level of satisfaction right after the sessions on a 1 to 7 scale, ease of use from very easy to very difficult. So there's no significant differences here based on health literacy. This is felt relationship with the agent from stranger to friend. It is significantly greater for individuals with low health literacy than high health literacy. High levels of trust. But when we started looking at health literacy, computer literacy also, what we found was we saw the highest scores for those with low health literacy and low computer literacy. So this is satisfaction across the board. And the lowest scores were those with high health literacy, high computer literacy, especially with the social agent. So there's some evidence. This is where I started thinking that maybe computer literacy is a factor in this, that people who are proficient with computers don't like this narrative format, and they have to sit through this whole half-hour-long conversation. This also shows up on the HCAHPS. This is a standardized measure of patient satisfaction with a hospital experience collected on the phone 30 days post-discharge. So this is for individuals with low computer literacy related their hospital experience as being more satisfying if they talk to the social agent with all of the jokes about the Red Sox, empathy, and that sort of thing. And those with high computer literacy scored lower in that situation. Okay. How long do we go to, Terry? 2. Oh, until 2. Okay. So I already gave you the quick synopsis of this one, but we've been looking at a number of ways of enhancing long-term engagement for longitudinal interventions. So whether it's exercise promotion, diet promotion, medication adherence, we just want to get people coming back and talking to the character over and over again and looking at ways of doing that. And so one of the tools we have is we have a group of 30 older adults who are talking to one of our exercise coaches every day. They've been doing this for 2 years now, and we can dynamically change the dialogue on the back end to run longitudinal studies and see how they respond to it. So the study I was just mentioning is how human should our agents be? Should we have them talk about themselves in their childhood? So we had one of the exercise trainers working in our group tell us a bunch of stories about herself, and we built a little storytelling engine that would have a social chat with you about the character's background. So I'd like to tell you some stories about myself, and when my family was living in Falmouth and so on. And then we manually also converted these to third person so that they were told about somebody else that the character knew. And basically what we found is this is over a month and a half. Significantly higher levels of self-reported enjoyment with the first-person stories, no difference in dishonesty and overall low levels of dishonesty, regardless of what kinds of stories the character was telling. And this is likelihood of logging in on a given day over the month and a half of the study. So they're both declining, but it's significantly more logins for the first-person story group. So to me, this is sort of opening the door to now, okay, we can bring in all kinds of social storytelling on the part of the agent to maintain engagement. And patients aren't necessarily going to feel that they're being deceived in some way. But it might help them get healthier because we're getting them to come back and talk to the agent more. Okay. So I think that's what I had. Questions?
Okay.
Oh, that's right. Yeah, the animated ones. Yeah.
So what's your threshold for computer literacy? I'm just curious.
We just simply ask them how much experience they've had with computers, from never having touched one up to being an expert on a simple scale measure. So we don't actually ask them in a number of different domains.
So throughout the talks, you kind of hit on something that was continually interesting to me, especially in studies like this. And how do you phrase interview questions such that you can ensure that the patient or the subject gives you actual honest feedback, rather than saying something that they feel you want to hear, especially if they're in low socioeconomic status type people who are being interviewed by PhDs and doctors.
Yeah, that's a very good point. And there is that bias there in most of the studies that we do where it's one of the researchers talking to the participant. In some of the more standardized measures like the HCAHPS or they try to have an objective third person call them several days after the fact, like 30 days post-discharge, to collect this information. But for most of the lab studies or the pilot studies that we do, where it's a researcher talking to them, that's a very real issue.
Yeah, a follow-up on that is, it's for exactly that reason that I found the behavioral measures that you showed, like much more likely to log into the system, much more persuasive than the Likert scale measures. So the 75% of people preferred by interface. The reasons why you explain for that being true are persuasive, but a different story could say people were just being nice.
Yeah.
Whereas for the behavioral measures, like I think it's very clear that the cause is your interface, which is really cool.
You're going to get a bunch of iPads to test this out?
Well, we're talking to the docs now about, so I think this whole inpatient experience is something that's ripe for intervention, that there hasn't been very much work done on, especially since they have lots of time sitting in the hospital room. So in fact, we're talking about, so can we have a hospital buddy that's sitting there with the patient during their whole stay, that's telling them what's going to happen next, reducing their anxiety. When the provider runs in their room to do rounds, it tells them who it is and why they're there and what kinds of questions they might want to ask them. So sort of looking out for the patient and helping them through the process.
One of the comments.
And on an iPad, that's why that triggered that.
Some of the comments did talk about being able to ask a question as many times as possible, not being embarrassed. So recognizing the fact that it's not an interaction it's an interaction with the system, not a human being, but then also this interest in exploring backstory. What might be a backstory, might be how's your mother doing? Well, then we have to advance. So you see things where reality are nebulous in an interesting manner. And so when you talk to what going to be on the study, what sense do you get from the people that are the elders that are using this? What's sort of directions? What's their basic understanding of the system? As opposed to the health population, the study that you're doing.
You mean what do they think is behind the character or their attitude towards?
Yeah. What do they think of? They're aware that there's a designer behind this.
Yeah, I've had them.
The committee that sat around the table coming up with a backstory.
Yes, so I've had them make comments like, I can see all the work that's gone into the design of this, or speaking some to the design of the system. And other ones seem to just react to just enjoying the experience and talking sort of superficially about the character as if it were a person and how much they're enjoying it. So I've heard both of those stories from participants. Yeah.
So first I just want to say that I'm really inspired by this work. And I think it's great because it's got this really nice mix of like, you're out there doing something that's actually making people's lives better in a really big way. And also you're doing this really interesting, like precise research of, little points like, do we tell this story in first person or third person, and really figuring it out in a quantitative and deep way. And I think that's really exciting. And I guess the reason that I say this is, seeing this presentation really reminds me a lot of one of my favorite HCI papers, the Beyond Being There paper from Holland. And I think it'd be really interesting to see come out of this work, say when it's done, is some sort of summative paper on all of the ways that relational agents can be better than people or different than people in ways that people can't achieve these things. Because I think, early on in this talk, I was worried that it was going to be, we do almost as good as people if you do this sort of thing, and just always this comparison against people. I think that you've really shown that there's a lot of differences, and being able to put something out in the community that says, these are the ways that it's completely different. Seems like it'd be a really valuable way to make this work go further.
Yeah, well, thank you. And I think, unfortunately, one of the reasons why it's different is because the healthcare system is messed up, right? So, of course, doctors would potentially like to be able to spend infinite time with the patients, but yeah.
The agents, unlike doctors today, are interactive.
And they're consistent. There's lots of ways that we can.
But the second point you made, I mean, doctors do want to be consistent, but that's, something that's really hard about human nature in general. Like, people make mistakes, and agents arguably don't. I mean, so I think there are some things that are very indicative of, this is broken about the healthcare system, we should fix it. But there are probably also some things that, like, this is how humans are, and we can't fix that.
Yeah. So we've had, in building the system that's going to follow patients home, we've had lots of interesting discussions with the doctors about, so what role should that agent play? Should it ever actually tell the patient, you need to go to the hospital right now, or do any sort of diagnosis? And so far they've just wanted to completely avoid that. So all we do is we ask them questions, and if we detect an emergent condition, we flag a clinician to pick up the phone and call the patient. And that's all we do. So we want to just avoid the whole medical decision-making thing, at least for now.
Is that, I'm just really curious, because I hear a lot of people say that sort of thing when they're working in this space. Is that because of liability and getting sued, or why is that? Because there's evidence that show that, like, decision trees do better than doctors in diagnosis, right? So is that just a
I think in our case it's it's just conservatism, that this is our first foray into doing this sort of thing, and in medical establishment in general, you just sort of want to, you want to fall back to having a person talk to the patient. That's like the default action. And so maybe once we've done that for a few years and proven that works, and we have some well-defined situations that we can actually tell the patient, you should go to the hospital, then we can go ahead and give that advice automatically.
Darren, you mentioned sometimes about how this relates to the state of our healthcare system. Have you thought about, or have you had contact with people from other countries to see if the same things hold there?
Well, we know there's folks from other countries who are interested in doing this kind of discharge interaction. So I think this is a common phenomena, that's a point of transition that's not well attended to in particular, that they don't spend a lot of time with patients.
I was thinking about the sort of preference of not to have a doctor. If doctors behave differently in a different culture, that might not be the same preference.
Yes. So that would be a great study to do, but yeah, I don't know.
I see an analogy of the Toyota debacle right now with this situation, but anyway, that's not to denigrate. The way back we knew when you wanted a computer being involved, fly-by-wire, it used to be called versus mechanical bias. That you want to have more redundancy, triple redundancy. All the things they didn't do, by the way. I mean, Toyota is now learning what way back we knew what we should do if we actually automated. Mm-hmm. And I see the same process happening here. At least potentially that, yes, a number of things we could find out before. I sort of agree with the medical professional reaction, but for somewhat different reason. I mean, there's all kind of things in here hidden. And if you want to let the system doing diagnosis, that are probably around, but have never been really put together properly, just like that fly-by-wire system. I wasn't surprised that Toyota had a problem to this one. So I might not be surprised if you guys have a problem if you automate the world even.
I think, yeah.
That's speaking through here. So I don't like the cartoons, by the way. I rather use the video.
Video, okay.
Either direct interface or video slides, spoken audio over slides. I hate cartoons.
You have an opportunity to take all
Wrong
content now in this room. Ask that question.
Well, let's go. First of all, what's your level of computer literacy? So I imagine it's all pretty high. So I can get half of the equation here. Yeah.
The eyebrows were really scary. The eyebrows, because they're no relation.
Speaking of that, this is a phenomenon I'm sure you've talked about many times, the uncanny valley.
Yeah.
Do you have a sense from your experiments how well this particular crossed over that?
Only through the many people that have used these systems and don't seem to comment that they seem unnatural somehow or that they don't like interacting with it. I had, in some of my earliest systems, we were using very old speech synthesizers, and I had a lot of people complain about the voice. But I found that in our longitudinal studies that even if I could just get them to have 2 or 3 conversations, that they grew accustomed to the voice, and then after 2 months, they actually grew to like it. But I guess my attitude is, so I started out with this cartoon rendering because I was putting this on very old computers without graphics cards many years ago, and this was an efficient way to do it. But I only wanted to be able to animate those nonverbal behaviors that we know how to do well, and not, not have any more resolution than that, is my feeling. But I haven't played with that experimentally to see how patients would respond.
It seems like there's so many different variables in space. And so pick on some of them and test them out, and sometimes it takes a long time to really understand if one variable outperforms another variable, or one setting outperforms another setting. So it's interesting, like what's the minimal amount of time it takes to actually understand a design direction? Is it mostly intuition that you're using to kind of decide how to make the system better?
Well, and talking to patients who are using the systems. And so one of them had said in some of my earlier studies, wouldn't it be great if the character could just change its clothes occasionally, which was like, I knew early on that variability in a long-term interaction was a big deal. So yeah, it takes a long time to run these longitudinal studies, and my feeling is a lot of the studies that are done in single session, HCI lab interactions, especially with characters, just don't hold up after 30 conversations or 100 conversations. That, it's a different set of issues once you project out a ways.
100 conversations to really understand if the variable.
Well, okay, well, let's say
So, like,
20 anyway, but yeah.
After X number of conversations, then you change the clothing, and then you change this.
Or you're looking at variability over time versus constant over time, and do 20 conversations and then see what the outcome looks like.
And I'm curious about this. We talked about this before your talk, about the idea of having human operators or nurses or some sort of experts monitoring the interactions in real time.
Yeah.
And somehow injecting when there's interaction breakdowns or when they sense that the patient is getting frustrated. Have you explored that at all?
So in the system that's going to follow patients home from the hospital, and if they have a problem that the nurse picks up the phone and calls them, the nurse can also change the parameters of the system on the server. So it can change the medications that the patient is getting and their follow-up appointment information, so that sort of stuff. So we're doing it asynchronously. But no, we haven't gone to that space yet, which is actually either in real time watching the conversation or looking at log files to see what happened in the conversation, and then deciding how to maybe subtly change the behavior of the character. Like, that motivation strategy is not working. So today let's try motivational interviewing or something else. Yeah, I think it's an interesting area.
By the way, that's what I had in mind for learning additional things that you need to get there. Do things in real time. I told Feigenbaum way back, we should have human-computer interface. And the nurse listening in the background helps improve the system behaviors for the programmers, but also make sure that the patient gets the right thing. Eventually, yes, you can reduce the number of intervention by the human and get your HCI finally, when he converges, if you wish. But some of the statistics take long, like authorship recognition takes 30,000 characters to converge statistically. There are all kinds of long-term statistics that if you don't pay attention to that, yes, you'll never get there.
Yeah. Well, I was telling Stephen that there's also an opportunity for doing, I think, interesting three-way conversations. So there's many large companies in the U.S. who do chronic disease case management. They're responsible for a panel of patients with diabetes and have to maintain their glucose level within some range. That pick up and counsel the patients by phone. So if they had an agent that could also be counseling the patients and then knowing when to hand off to the agent and when to step in themselves or change the parameters of conversation is another very interesting space of exploration, I think.
You had mentioned that there are family members or caregivers involved, especially with respect to the elderly transition care. Very often, there's someone else, either a family member or a professional caregiver that is involved in that transition phase, not their ongoing well-being. What avenues do you think for interaction with those?
There's been some projects not using characters I know of that have tried to just provide, say, social support for the caregiver, because it can be often a very burdensome job, thankless job, and they're under a lot of stress. So trying to provide not only information to them, but just basic empathy and support, emotional support for them in this caretaking process. So I think that's one opportunity, as well as specific information about the condition of the loved one that they're taking care of that they can make use of. Yeah.
Have you done any work on using the system for children, either children who are leaving a hospital to kind of better understand their experience of why they were in the hospital and what they might need to do, or alternatively for children of their, basically if their parents were in the hospital and they're checking
Oh,
out.
interesting. So first of all, I have not done any work with children. That's a whole other unexplored space. But no, and dealing with other family members, which was this other comment. No, I haven't looked at that yet. So. Okay.
Okay, well, yeah, one quick comment and then a question. First, related to children, I think that'd be a great idea, especially because given the computer literacy of a lot of children in the U.S., you might find that you can elicit more information from children about their experience using an agent than using an adult. And so you might actually be able to learn a lot about their healthcare experience. And then I was wondering if you have any preliminary results on the impact of race and gender of the agent, or if it's still in progress.
So looking at our process measures so far, which is what we have for the discharge nurse, there's no results right now. Manipulating those. Trying to remember the researcher's name. There was somebody who did a study on racial concordance in conversational characters in a health counseling domain. And if you see me afterwards, I can think of her name. Deborah Roeder at Johns Hopkins.
Okay, thank you.
For more, please visit us at stanford.edu.